Hello guys, good evening. Can you hear me? Can you hear me and see me? Cool. Okay. I think there are already quite a few participants are there, so that we can start the session. I think you can hear and see me well, by the way. So where we have been discussing already is on the natural history of hepatitis B virus. And do you have any doubts in that? Because Siddharth has replied, and there are some other students, quite a few students are there. So do you have any doubts till now, so that you want me to tell again, so that we can go back to the discussion on the viral hepatitis? You don't have any doubts, right? All right. Okay. So let us move on. So because I'm not getting any messages, so it's better that I move on to the next set of discussion on viral hepatitis again. So we have seen the natural history of hepatitis B virus, and next thing to understand about the hepatitis B virus is the structure of the genome. The genomic structure of hepatitis B virus is quite important. So what is going to be the genomic structure? So after the genome, we need to know about the different viral proteins and their constituents, and how they are helpful in the serological principle. And at the same time, after that, we also need to know about the chronic HBV cycle and stages. And after that, we need to know about the uh, how this can be extrapolated into the treatment structure. So now let us see the genome first, genome and structure. So in hepatitis B virus, the DNA will be arranged in something called as open reading frames. We call them as ORF. So basically there are three ORF that are very, very important. So one is going to be the ORFP that produces the polymerase, basically, that is called ORFP. Then second one, we have something called as ORFS, which produces the surface antigen, which we'll be seeing after some time. Then there is something called as ORFC, open reading frame C, which produces the core proteins and probably even the E antigen, E protein also. But apart from that, one other thing that is not often very important for your understanding is the ORFX, that produces an X protein, which we don't know what their function is. So typically we don't know what function this X protein plays really. But it produces something called as hepatitis B X protein. So it is thought to be a transcriptional activator. And it's been postulated to be playing a role in the development of hepatocellular cancer. Again, we don't know whether it really plays a role in hepatocellular cancer, but it's been thought that it plays a role in the development of hepatocellular cancer. But we'll stop the ORFX there and we'll move on to the ORFP, S, and ORFC. So first of all, ORFP. So ORFP is going to produce the standard HBV polymerase. This is the polymerase enzyme that the hepatitis B virus carries. This is hepatitis B virus polymerase, which has basically four domains. In that you have a 3 enzymatic domain and 1 non-enzymatic domain, which is beyond the scope of the current discussion. But HBV polymerase is a very important enzyme because it has some specialized function, because it has polymerase function. At the same time, it has reverse transcriptase function as well. I think everyone would have heard about the Baltimore classification. We have something called a Baltimore classification, which classifies the virus into 7 different categories. In that, hepatitis B virus comes under Baltimore 7. It's one of the only viruses that present Baltimore 7 because it contains a polymerase that has a polymerase activity. Apart from that, they does have a reverse transcriptase activity as well. So that's why it's a very special kind of polymerase. And apart from that, we do have the ORFS, which has 3 subdivisions in that. So if you really want to classify what are the ORFS proteins, so we have something called as a pre-S1, then we have a pre-S2, then we have the classic S protein. So this S is the one that produces something called as a small surface antigen alone. This S alone produces something called a small surface antigen. Then this pre-S2 and S together produces something called as a medium-sized surface antigen. And all these 3 things together, the pre-S1, pre-S2, and S, all these 3 things together generates a kind of a surface antigen called as a large surface antigen. So this large surface antigen is what we refer to as a major surface antigen. And the other two are what we refer to as a minor surface antigen. So we have three different sets of, three different sets of surface antigen. And of course, the most important of all is the large, the major surface antigen, which is produced by the pre-S1, pre-S2, as well as the ES gene. Most importantly, this surface antigen is absolutely non-infectious. So that is the reason why we are using that for vaccine formation. And we know this is a outer protein. So antibodies against the surface antigen are going to be protective, which I've told you already, because this is an outer envelope protein, or protein that form the outer surface of the virus. So antibodies against this outer surface proteins usually are tending to be protective, which we have discussed already. So antibodies against this will be definitely protective. And remember, this is always produced in excess. Always produced in excess to that of the total number of viral particles, which means if you have one viral particle, the number of surface antigen that will be produced will be like 10, 20. So which means the surface antigen is almost always produced in excess compared to the actual viral particle. Please understand, this surface antigen is the one that previously was called as something called as an Australia antigen. And the complete viral particle is what we refer to as something called as a Dane particle. And the reason is because initially they found out the surface antigen alone. They found the surface antigen to be protein only. So this is the history of how hepatitis B has been discovered. In 1960s around, they found out patients were having hepatitis and hepatocellular cancer and chronic liver disease, cirrhosis and all. And in those individuals, they found out surface antigen only, because surface antigen is always produced in excess. And once they analyzed the surface antigen, they found out it's just protein. They didn't have anything else at all in the virus apart from the surface antigen. So they felt that it could be probably Prion's disease, because Prion's disease is something that is produced purely by a protein. It doesn't have any DNA, RNA or anything. So they thought hepatitis B virus is also like a prion disease where protein is causing the hepatitis. But later on, they understood that this is not the main reason for developing hepatitis. It's the full virus particle that is the reason for developing the hepatitis. And later on, once they found out that full viral particle, and that is what they named it as something called as a Dane particle. So Dane particle is a full viral particle, whereas the surface antigen is what we refer to as Australia antigen. It is almost always produced in excess compared to that of the full virus particle. That is a Dane particle. And what is the function of this hepatitis B surface antigen? In reality, for the virus, it should be useful. So the usefulness of the surface antigen from the virus point of view is the fact that it induces something called as a T cell exhaustion. So by inducing T cell exhaustion, it can escape the immunity, and that's how the surface antigen is helpful for. And what's going to happen? For example, let us assume, maybe I can put an ink to shape. Maybe if you take, this is the surface envelope, and let us assume these are the major surface antigens, or maybe small surface antigen. So these are the small surface antigens, to be honest. So let me put this a small surface antigen. And certain areas you have the medium surface antigen also. Medium surface antigen also. Not all, certain areas you will be having a medium surface antigen also. And in certain areas, you don't only have the medium surface antigen, you do have the large surface antigen as well. So which means there are areas where there will be large surface antigen, there will be medium surface antigen, at the same time there will be small surface antigen, which means this is how heterogeneously it's been distributed on the surface of the envelope. So this is this black color thing which I've drawn as the envelope of the virus. And on top of that, you might be having only small surface antigen, or you might be having small and medium surface antigen, or you might be having a combination of small, medium, and large surface antigen. So the combination of all these three things is what we refer to as something called as a large surface antigen. So this is how heterogeneously the surface antigens are arranged on the surface of the viral envelope. So if you take this envelope alone, suppose if you take this envelope alone that contains surface antigen only with nothing in it, which means you don't have anything inside it. It's completely empty. So only the envelope with only the surface antigen on the surface, without any DNA, without any other capsule, or without anything inside, is what we refer to as Australia antigen. And that is why I told you the surface antigen is always produced in excess compared to the entire viral particle. Suppose if you have something in between, I mean inside that, so if you have a nucleocapsid, you have the DNA and the DNA polymerase, you have other proteins, then that will be a virus particle, and that is not Australia antigen. That is what we refer to as the DANE particle, that is separately. Usually this Australia antigen, that is enveloped alone with surface antigen only, without any other part, I mean substances inside this envelope. It's an empty particle which is non-infectious, which is called as Australia antigen. Is present in two forms basically. One is called as the spherical form, which is 22 nanometer in diameter, and second one is the tubular form. In both forms it is arranged, so it can be in a spherical form or it can be in the tubular form. So what is the HBV particle then? So this is the Australia antigen we talked about. So which means the surface antigens are always produced in excess compared to that of the net virus particle. But what is the virus particle made of then? So if you take the virus particle, so I can draw the nucleocapsid also here. So this will be the entire viral particle. So I can draw the surface antigen here on the envelope. And of course, you are going to have certain areas, the medium surface antigen also. And in certain areas, it will be made of the large surface antigen, which you have studied already. Okay, just for understanding, I've drawn this, so no need to take it seriously. So the one which I have drawn is the capsid, otherwise referred to as a nucleocapsid. And this is the classic large surface antigen we are talking about. And this is the envelope. And of course, you're going to have a DNA polymerase. So this is the HBV DNA polymerase that is there. And along with that, you will be having a HBV genome. As I told you, HBV genome will be arranged in something called as a open reading frame. So this is the genome. So of course, HBV is a DNA virus. And what kind of DNA? This is a very important question for the exam. They'll be asking you what kind of DNA that you get with hepatitis B virus. It is the partially closed double-stranded DNA. So that's what you will get. It's not a fully, completely closed double-stranded DNA. It's actually a partially closed double-stranded DNA, or simply referred to as a partial double-stranded DNA. One old Chipmer question, I think in 2013, they asked what is the length of this double-stranded DNA. It is approximately 3.2 kilobase pairs. So that is the average length or number of base pairs that is present in the HBV genome. That is 3.2 kilobase pairs. And this entire particle, so with something inside. So this is what we typically refer to as something called as a DANE particle, which I've told you already. So if you have only the empty envelope with only the surface antigens on top, that will be called as Australia antigen, available in two forms, spherical and tubular, always produced in surplus. And that is what we call as Australia antigen. And if you have the genome and the entire viral particle packed, so this is what we refer to as DANE particle. It's almost always infectious. So this is the infectious particle, by the way. The Australia antigen is not infectious. So this is the basic anatomy of the virus. And then we have the different types of genotypes. So if they ask you what is the genotype that is common in India, so if you take for the hepatitis A virus, it is genotype 1. Hepatitis E virus, it is genotype 1. But in hepatitis B virus case, it is the genotype D that is more common in India compared to that of A and C. So as far as the genotyping is concerned, for hepatitis A, for hepatitis E, and even for hepatitis B, it is not important, which means the genotyping is really not important for hepatitis A, E, or probably even B virus. But for hepatitis C virus, the genotyping is very, very important, which we'll be discussing subsequently, because the genotyping is the one that really helps in deciding the treatment. At the same time, the virulence and the severity of the disease also depend on genotypes for the case of hepatitis C virus. But for hepatitis B virus, it is not that important at all. Okay. So now there are some serotypes are there. So we have some serologic subtypes, which was once upon a time question in NEET PG, like in 2017-18, they asked 1 or 2 times, what are the serologic types? It's based on antigenic epitopes present in surface antigen. So the serologic subtypes is totally based on the antigenic epitopes that are present in the surface antigen. So it's totally based on surface antigen, antigenic epitopes. That's very important to know. So in that, the A will be, there are four serological subtypes basically. In that, A will be the standard. A will not change at all. So, but there are two other things. So first of all, we have A, which will not change at all. But there are two other things. For example, it could be either Y or D, or it could be the another two will be either the second spot will be Y or D, and the third spot will be either W or R. So these are the serological subtypes, which means what I'm trying to tell is the first antigen will always be A, the second antigen will be either Y or D, and the third antigen will be either W or R. So based on that, you can give 4. So since A does not change, I'm writing all 4 A. And I told you it could be either Y or D, which means I can write Y or D, Y or D. And the third one will be either W or R, W or R. So that I can write W or R. So any one here. So we have 4 antigenic combinations here. One is AYW, ADW, AYR, and ADR. So AYW is typically seen in genotype D and E, and ADW is what we see in genotype, and that is the one that makes the genotype A, B, F, G, and H. Apart from the D and D, most of them will be having ADW combination only, which means it's the most common combination that is seen in the world. So I'm going to rub this off because I'll tell you in some time why is the case. And for genotype C, it could be either AYR or it could be ADR. So this is for the genotype C. So that's how it's going to be. So if they ask you what is the most common genotype in India, I told you it's genotype D that is going to be the most common. If they ask you the most common serological subtype in India, once again, I'm going to answer it is ADW, AYW. So that's why this is important. That's why I rubbed that most common previously, even though this is the most common combination in the world. But from Indian perspective, this serological subtype is going to be the most common. So D, genotype D is the most common. So AYW serotype is going to be the most common. So which is clearly important. And as far as the cell cycle, the cycle of the hepatitis B virus within the cell is concerned. So let us it's not there. 1 second. Let me draw the cell cycle there. So that's why I wanted to draw it. So let me draw the hepatocyte over here. Hopefully, yes. And we have the nucleus. We have the nucleus here. So I think this must be enough so that we can move on. So first, we need to know how the virus enters the cell. So there are two things that is important for virus to enter the cell. One is the heparan sulfate. Let us assume this is the heparan sulfate. But this is not very important because it forms a loose binding only with heparan sulfate. But later on, once it binds with heparan sulfate, it forms a very tight binding with the second protein, which is very important. That is called as NTCP, which is a bile acid transporter protein. That's called sodium taurocolate co-transport protein. N stands for sodium, and T stands for taurocolate. C stands for co-transport. P stands for protein. So it's a sodium taurocolate co-transport protein. So it forms a tight binding with sodium taurocolate co-transport protein, through which the virus basically enters the hepatocyte. So once the virus enters the hepatocyte, it is going to enter by endocytosis. And from the endocytosis, basically, it will be unsheathed. Once it is unsheathed, you are going to release the nucleocapsid. So we have seen the nucleocapsid here. So this nucleocapsid will be released into the cell, so which contains that partially closed double-stranded DNA and a DNA polymerase. After that, you're going to release the DNA particle alone. So I can write as this partially closed double-stranded DNA. The host enzymes, as for many of the viruses, the host enzymes are the ones that is going to complete the closure of this double-stranded DNA, which is now called as cccDNA, which is a very important process, which is done by the host itself, which produces the cccDNA that is called as covalently closed circular DNA. It's a closed DNA. So initially you had a partial double-stranded DNA only, partially closed DNA only. The host enzymes itself now will act upon and convert the partially closed double-stranded DNA into covalently closed, that is fully closed, covalent closed circular DNA. Then once again, the host itself, the host enzymes itself are going to work upon, and they're going to convert this DNA into multiple mRNA particles. Because the virus DNA is arranged in open reading frames, you will be getting mRNAs of different length, and the biggest mRNA. So the largest mRNA is what we refer to as a pgmRNA. The largest mRNA is what we basically refer to as a pgmRNA, and is the main mRNA. So I can shade only the largest mRNA, which is going to be really important. And these small mRNAs, of course, they are going to go and produce the proteins in the ribosomes, because once they go into the cytoplasm, they will be converted into viral proteins by the ribosomes. Fine. But this largest mRNA, which is also referred to as something called as a pgmRNA, so that will be acted upon by the HBV polymerase. Now you have that enzyme, special enzyme that is also coming along with the virus, that is the HBV polymerase. And this HBV polymerase will be now producing from this mRNA. So you know very well what is the function of HBV polymerase. Initially, what it does is it takes the biggest mRNA and it's going to take a template of this mRNA and produce a complementary DNA strand. So from an mRNA, if you produce a DNA strand, you will call it as a, that is actually done by reverse transcriptase activity. Now, it has its polymerase activity. Through the polymerase activity, it will produce another strand of DNA as well. Now you are getting a double-stranded DNA. So that's why it has two functions. So one is the most important is it has the reverse transcriptase function. At the same time, it is going to have the polymerase function as well. So that's why it's a very special enzyme. So same enzyme that is called as HBV polymerase does two functions. Initially reverse transcriptase, then it acts as a polymerase. It is going to produce double-stranded DNA. So what double-stranded DNA is going to produce? It will be producing only probably a partially closed double-stranded DNA, which will enter the cycle once again. So once again, the same process will continue. And remember, some of this, not all, some of this double-stranded DNA, so this is partial double-stranded DNA, will be packed with the viral proteins. So will be entering the viral proteins and they will be producing the viral particles. And these viral particles, once they come out of the cell, through the cell membrane, they acquire the envelope. This envelope is basically acquired from the host cell membrane only. So, and they form the complete viral particle now. And all these things. So it will be released and they will start infecting the next cell. So that's how the life cycle is going to continue. So there are certain few points that the examiners will be fond of asking. One is going to be this NTCP transporter, which is very important. That is the key for entry of the virus, which forms the tight binding with the heparin sulfate. Even though it forms loose binding, it's not that important, but NTCP is very important. That could be an exam question. And second, formation of this covalently closed circular DNA is a very crucial step. And apart from that, this pgRNA's conversion to DNA by the activity of HBV polymerase is again very important, which has two different activities. One is the reverse transcriptase and it has the polymerase activity. Remember, it also has something called RNase-H activity, which is something beyond the scope of the current discussion. That is a true microbiology discussion. But basically, it has RNase-H activity also. It doesn't only have the reverse transcriptase and it doesn't only have the DNA polymerase activity, it also has the RNase-H activity. So this is the basic life cycle of hepatitis B virus in any hepatocyte. So that's how it's going to work upon. So having known about the life cycle of hepatitis B virus, so first of all, you need you need to know about the cytopathic nature of the hepatitis B virus. So that's what we called as immunopathogenesis. As far as immunopathogenesis of hepatitis B virus is concerned, the virus basically is not cytopathic in nature. Remember, hepatitis A virus is cytopathic, hepatitis E virus is cytopathic, and hepatitis C virus is also cytopathic, but hepatitis B virus is not considered to be cytopathic, or you can ask that hepatitis B virus is one of the least cytopathic virus, which means you don't see any cytopathic changes because of the hepatitis B virus, which means it doesn't kill the host cell. Then what kills the hepatocytes and what causes the hepatitis is the immune damage. So number one, the virus is not cytopathic, and number two is the immune damage that damages the hepatocytes, and most important is the CD8 cytotoxic T lymphocytes. And of course, we know the protection from virus is basically coming from the cytotoxic T lymphocytes only. It's not coming from the CD4 T helper cells. So CD8 T cytotoxic T lymphocytes is the one that is the main problem here, and that's going to kill the hepatocytes, and that's going to cause the death of the hepatocytes. And you do develop some antibodies against the virus. We know there are some non-protective antibodies which are formed against the inner part of the virus, and there are protective antibodies that will be formed against the outer portions of the virus. So what are the non-protective antibodies? The anti-HBC, the core antibody, and anti-HBE against the E antigen is basically non-protective. And as far as protective antibodies are concerned, anti-HBS is going to be the protective one. So it's formed against the outer surface antigen. So anything that forms against the outer surface proteins are likely to be protective in nature. So anti-HBS is likely to be protective. But more importantly, I think nobody has told me that we have not discussed about this ORFC at all. So we have something called the ORFC, which we have not yet discussed, which has two components. Like we have one is called as a pre-C region, and second one is the C gene. And of course, the C gene is going to produce the hepatitis B core antigen, and this combination of C and pre-C is going to produce something called as hepatitis B E antigen. So which means this pre-C region is very important for producing E antigen. That's the take-home point. So the pre-C region is very, very important for producing the E antigen. So pre-C and C together will produce the E antigen, and C alone will produce the hepatitis B core antigen. If somebody asks you which is the only antigen that is not seen in the blood, basically it is hepatitis B core antigen. Hepatitis B core antigen is basically something that is not present in the blood, which you cannot measure. But the antibodies against the core antigen can be measured. So, but C antigen is something that does not come into the blood in the first place. So after knowing the immunopathogenesis, now I told you there are one protective antibody and two non-protective antibodies, by the way. And then with this, we need to know about the chronic HBV stages. Or maybe we can think about discussing about the serology first, then we can move on. So when I want to talk about serology, you need to really be aware of that, because I'm going to ask a lot of questions on serology. So be ready to answer. So first of all, let us talk about the surface antigen. So what are the characteristic features of surface antigen? As I told you, it is always produced in surplus. Even at very low levels of viremia, the surface antigen will be produced. Even if the virus itself is not detectable in the blood, the surface antigen, because it is always produced in surplus amounts, it will be positive. That is the reason why it is considered to be very sensitive marker for hepatitis B infection. For hepatitis B virus infection, this is considered to be very sensitive marker. That is why current screening tests employ surface antigen. But whether surface antigen is the gold standard or not, answer is no, because there are some cases where surface antigen can be negative, but still the patient may have infectious particle in the blood. So there are conditions like maybe window period, which we'll be talking about that in some time. And after that, you have something called an occult HBV infection. So where surface antigen may be negative, but patient can still be infectious. So whenever surface antigen is positive, that is equal to infection. That's all. So this is the rule. Surface antigen positive means that's equal to infection. Very rarely you'll get a false positive surface antigen, but surface antigen positive means it is equal to infection. Surface antigen negative means it's not always equal to no infection. You cannot rule out an infection, but even though in reality, because we use as a screening test, whenever surface antigen is negative, we rule out an infection. But surface antigen is negative, but still sometimes patient can be infectious. What are the areas where patient can still be infectious despite having the fact that surface antigen is negative? One is the window period. We'll be talking about them sometime. And second is something called as an occult HBV infection. Occult HBV infection. But remember, whenever surface antigen is negative, it means usually the patient is non-infectious. That's the meaning. But rarely, sometimes the patient can be infectious in two conditions which is typically called as window period, or second one we call it as a occult HBV infection, which we'll be discussing in some time. But please understand, it's antibody, that is anti-HBS. I can write down, whenever you form an anti-HBS, which means the patient is right now having no infection. Right now, the patient is not having an infection. That's what is the meaning of anti-HBS. The only exception is again occult HBV infection. Only exception is possibly occult HBV infection. That is the only place where anti-HBs can be negative, but still the patient can be infectious. But whenever anti-HBs is there, means patient is not having infection. That's what it means. Anti-HBs can be, I mean, number one, it is a very important protective antibody, very, very important protective antibody, which means it protects you against the infection, and which means you can't have the infection if you have anti-HBs, except the case of occult HBV, which we'll be discussing. And second thing is the fact that whenever anti-HBs is positive, there are only two possibilities. Whenever anti-HBs is positive, there are two possibilities. Usually, it must be either a resolved infection, which means the patient had an infection in the past, but they have cleared the virus. It's a resolved infection, or the patient is having a vaccinated status. In patients who are vaccinated, you can have a anti-HBs positivity. But third rare possibility where you can have anti-HBs is occult HBV. These are the only three conditions where you can have an anti-HBs positivity, but usually in exam, these are the two things that you need to think about. One is the resolved infection, and second is the vaccination status. And next is the hepatitis B core antigen. So this antigen is something that is not seen in blood, which means it is something that is not measured usually. But we have the antibodies that is very important diagnostically. One is the anti-HBC IgM antibody. So whenever anti-HBC IgM is there, it is, I mean, it means there are only two conditions. So in fact, three conditions. One is it must be an acute infection, or it must be a window period, number two. And number three, it can be seen in sometimes in a flare. Flare is referred as an acute on chronic HBV. Acute on chronic hepatitis B virus infection. So which means it's a flare. So during flare, it can be positive, but usually it disappears in chronic infection. Very commonly it disappears in chronic infection, except for the time of flare, it can reappear, but generally disappears in a chronic infection. But any acute or window period, anti-HBC IgM is considered to be the gold standard. So to diagnose an acute infection or to diagnose a window period, anti-HBC IgM is supposed to be the gold standard. Then we have anti-HBC, total anti-HBC. So total anti-HBC is very non-specific. Remember, in textbooks, they will give anti-HBC IgG, but I can write as a total anti-HBC. Total anti-HBC means it includes IgM, IgG, everything. So that is what we have. That's what we call as an anti-HBC total. What are the areas where it can be positive? Remember, anti-HBC total is very non-specific. It can be seen in acute. It can be seen in window period. It can be seen in chronic infections. It can be seen during flare. It can be seen in occult HBV. It can be seen in resolved infection. So which means in a wide variety of cases, you will be seeing anti-HBC total. So anywhere in this spectrum, you can see anti-HBC total. So the only place where you don't see anti-HBC total is in vaccinated status. In vaccinated individuals, you don't see anti-HBC. So this is the only place where you do not really see anti-HBC total. Remaining every other situation, you will be seeing anti-HBC total. So that's all. If you specifically want to know that anti-HBC IgG will be seen or not, anti-HBC IgG, but this is not measured. Anti-HBC IgG is commercially not measured right now in India, very commonly. So if you really want to tell anti-HBC IgG where it will be seen in chronic infection. It will be seen in resolved infections. Sometimes it can be seen in occult HBV infections, but it will not be seen in, of course, vaccinated. Or it can be seen in a patient who's having a flare of a chronic HBV, acute on chronic HBV. You can see during that situation also, but it will never be seen in acute infection. It will not be seen in window period. It will not be seen in vaccinated individuals. But really, this is something that is not measured in reality. In reality, what we measure is the total anti-HBC only. That's what we measure. We don't really measure anti-HBC IgG in reality and clinical practice. But if you want to know, this is the idea. Then we have HBe antigen, hepatitis B antigen. So this is coming from the pre-C region. So, this is coming from the pre-core region. And remember, HBe antigen is directly proportional to the infectivity, which means whenever HBe antigen is positive in the virus, it means the virus is highly infectious and the risk of transmission will be very high. For example, how you can tell is the fact that what will be the risk of needle stick transmission. Let us assume a needle stick transmission. Suppose if E antigen is positive, the risk of like infection is approximately 30%. Suppose if E antigen is negative, the risk of infection is only 6%. So this will clearly tell you if E antigen is positive, the risk of transmission is extremely high. So that's what they will have given in exams, that risk of getting transmitted through needle stick is approximately 6 to 30%. That's what they would have given. Similarly, if you have E antigen positivity, suppose if you talk about vertical transmission, if E antigen is positive, the risk of vertical transmission will be approximately like 70 to 90%. So that will be the risk of vertical transmission. Suppose if E antigen is negative, the risk of vertical transmission becomes 10 to 30%, which means clearly you can see that there is a substantially high risk of vertical transmission, again, if the E antigen is positive. So that is why E antigen is basically a marker of infectivity, which is very, very important. Basically a marker of infectivity. So if antigen positive, there is more risk of transmission of the virus to the individual. So apart from that, E antigen, I told you, E antigen positive means high degree of infectivity. E antigen negative means there is low degree of infectivity. Many times virus can convert from E antigen positivity to E antigen negativity, and this conversion from E antigen positivity to E antigen negativity is what we clinically refer as something called as seroconversion. This has a lot of meaning, and this is one of the very, very important events happening in chronic hepatitis B virus patients. Initially, they will be E antigen positive. After some time, either spontaneously or with the treatment, they can become E antigen negative, and this E antigen positive to conversion to E antigen negativity is what we refer to as seroconversion. And this is one of the important targets for treatment as well. So why you treat? Because you want to achieve seroconversion. That is the reason why you wanted to treat. Number one. And usually whenever they go for seroconversion, there will be simultaneous appearance of anti-HB antibodies. And this anti-HB is the reason why you get the seroconversion, because they stop the E antigen from getting produced. And anti-HB marks whenever anti-HB appears, it marks the disappearance of E antigen. And at the same time, anti-HB is only a partially protective antibody. It's not a completely protective antibody like anti-HB. Yes, it's only a partial protective antibody, or you can tell it as a non-protective antibody. It's not very protective, but just helps in seroconversion. That's all. At the same time, E antigen negative does not mean that the virus cannot replicate. Virus can still replicate even with the E antigen negative. E antigen negative and still the replication starts means we are dealing with something called escape mutants. We'll talk about that in some time. These escape mutants are also referred to as something called as pre-core mutants, which naturally do not produce the E antigen. Suppose in exam, if they ask you which of the virus strain which naturally does not produce the E antigen, by default is the pre-core mutant. Pre-core mutants, they naturally do not produce the E antigen. That is to escape from the anti-HB antibody, which we'll be discussing subsequently in some time. So fine. So we have different markers. Each one has its own importance. Surface antigen and its antibody, and C antigen and its antibodies, and E antigen and its antibody, anti-HB. And finally, we have the HBV DNA, which can be detectable in the blood. And if at all somebody asks you which is the most important marker of replication, most important marker of replication, most important marker that predicts the risk of cirrhosis, most important marker that predicts the risk of development of hepatocellular cancer, for all these things, answer is HBV DNA. If HBV DNA is there, it means the patient is infectious. The only place where patient may not have HBV DNA is in the window period. Sometimes, that too with current assays, it's very unlikely. But if HBV DNA is negative, but still the patient is infectious, means only that can happen in window period alone. That too if you use a low sensitivity assays. Apart from that, whenever DNA is positive, it means the patient is infectious. Whenever DNA is negative, which means patient is not infectious. The level of DNA directly correlates with the replication status, directly correlates with the risk of cirrhosis, and directly correlates with the risk of development of hepatocellular cancer. All these things are going to correlate well with the hepatitis B virus DNA, and the viral load of the viral load is actually predicted through HBV DNA only. These are the markers that you need to know. Then, what is the natural history of chronic HBV? So, we are coming to the conclusion of hepatitis B virus with this. So, what is the final take-home point on the cycle of chronic HBV, because previously, if you take the things we have discussed, we have already told about the acute hepatitis. We have finished that. We don't want to discuss on that. I told you the recovered patients, we have nothing to do with them. They're not infectious and they're not going to end up with any chronic problems. But the most important is this chronic HBV patient. So we need to know what is the fate of this chronic HBV. Naturally, you have some 4 different stages. The first stage, we generally call it as immune tolerance phase. You can imagine like a child getting infected. So this is the immune tolerance phase. You can imagine like a child getting infected. So during the immune tolerance phase, what happens is the immunity will be very, very poor in immune tolerance phase. Because the immunity is very poor, the virus will be proliferating so badly and they will be teeming with viruses. So the DNA typically tends to be extremely high, more than 1 million usually. But because the immunity is not there, I told you virus is not cytopathic and it's the immunity that generally kills the hepatocytes. The ALT levels generally tends to be normal. And of course, the E antigen will be positive here. Because, like virus comes fresh inside and E antigen will be positive, they'll be highly infectious. So this is what is going to be the case. And this phase goes to another phase called as immune active phase. Immune active phase. At some point of time, the immunity wakes up and the immunity understands that something is going wrong within the hepatocytes and there is virus that is proliferating within the hepatocytes. So the immunity tries to control the viral proliferation by killing the virus infected cells. And the viral levels and the viral load in the blood will come down, but will not come down very drastically, but still it will be more than 20,000. But to an extent, it's less. Here it is more than 1 million, here it is more than 20,000, which means still it will be high. Because we have not developed any protective antibodies, but at the same time, it is trying to control the proliferation of the virus by damaging the hepatocytes that are infected with the virus. Because there is a hepatocyte damage, the ALT level starts increasing. Typically, it will be more than 2 times the upper limit of normal, and E antigen will still be positive because it is unaffected anyways. And now the next stage is going towards something called as an immune control phase. So what do you mean by immune control? During this phase, the immunity has somehow achieved the control. And what is the main reason for the control? As I already told you, they will develop this anti-HBe antibodies. So this is a very, very important event in the history of hepatitis B infection, especially in a chronic HBV. So once they achieve this anti-HBe, the most important event that happens is E antigen will become negative. So this appearance of anti-HBe and the disappearance of E antigen is what we clinically call it as seroconversion, and it is one of the targets for different drugs that we use for therapy. We'll talk about that later on. And of course, once you have achieved a control of the virus is not replicating, because the moment it comes out, this anti-HBe antibody recognizes the virus and it kills them. So the virus tries to become dormant inside the DNA so that the ALT will become normal once again, because virus is not coming out. There is no proliferation of the virus. So the immunity also spares the hepatocytes. There will be no immune-mediated damage, and the DNA will be suppressed to mostly undetectable levels. It will be less than 2000. Mostly it will be to very, very low levels, undetectable levels. Finally, they move on to the last phase, because the virus starts thinking and it knows that the reason for the control that immunity has achieved is because of the anti-HBe. And the reason for the control by anti-HBe is because the virus is still producing the E antigen. So what the virus does is they start producing escape mutants. This is what we refer to as immune escape phase. During the immune escape phase, what happens is the virus naturally by itself starts withholding the E antigen. They don't produce the E antigen at all. These are also referred to as pre-core mutants. Virus naturally does not produce the E antigen. So they suppress the E antigen production. And at the same time, the ALT will start rising again because the virus will start proliferating once again. So these are the escape mutants. The virus knows that it's because the E antigen, the anti-HBe is able to achieve a control on the virus. Now, if they stop producing this E antigen, this anti-HBe antibody will become completely useless, and they cannot control the proliferation of the virus. And that's what virus does cleverly. They naturally stop the production of E antigen. But once again, they start proliferating, and immunity hopelessly, its last weapon, that is anti-HB, started getting wasted. So it hopelessly starts attacking on the hepatocytes and literally kills the hepatocytes, resulting in ALT elevation once again. And sometimes it's not that it should follow all the 4 classic stages. The patient can go from immune tolerance phase to immune escape phase directly also. At the same time, the patient can go from immune active phase to immune escape phase directly also. So it is not like the patient should follow all these 4 classic stages in a step-by-step fashion. But these are the 4 things that you need to understand. It's a very easy thing to understand. So this is how the virus goes in a step-by-step fashion. And if you ask me which time the patient go for cirrhosis, the highest risk of cirrhosis is with immune active phase and immune escape phase only. This is the time where there is a very, very high risk of developing cirrhosis. Cirrhosis risk is extremely high with immune active phase and immune escape phase only. But among the two, if you ask which is having the highest risk of developing cirrhosis, the immune escape phase is the one that has the highest risk or a maximum risk of developing cirrhosis. But there is something else that's also happening. The patient can go for hepatocellular cancer. Remember, they can go from immune active phase, they can go from immune escape phase, they can go from immune tolerance phase, and they can go from immune control phase also. Which means usually during immune control and immune tolerance phase, the risk of getting cirrhosis is negligible or it's not there at all. But the risk of developing hepatocellular cancer is there at all the stages. If you see, irrespective of the stage of chronic HBV, the risk of getting hepatocellular cancer is still there. So what are the reasons why you get hepatocellular cancer? There are 2 mechanisms why you get hepatocellular cancer. So I can write mechanisms of HCC. The number 1 mechanism is inflammation. So almost 50 to 80% of the cases of hepatocellular cancer will be due to inflammation, which means they will develop from a background cirrhosis. I told you the number 1 cause of hepatocellular cancer in the world is background cirrhosis. Irrespective of the cause of cirrhosis, cirrhosis itself increases the risk of hepatocellular cancer. Number 2, second reason why they can develop hepatocellular cancer is something called as insertional mutagenesis. Insertional mutagenesis. The numbers are variable. That's why I'm telling in the values in the ranges, like 20 to 50% is what some books code, and some books even tell 50-50. 50% is due to insertional mutagenesis and 50% is due to inflammation. But in reality, suppose in exam, if they ask you what is the most common reason for development of HCC in hepatitis B infection, it's always inflammation. That's what you have to tell. But there are a lot of books like SHIF which tell 50-50 chances, which means 50% is due to inflammation, 50% is due to insertional mutagenesis. What do you mean by insertional mutagenesis? I have told you the life cycle here, where you have this cccDNA formation. Sometimes what can happen is once this cccDNA is formed, some of the cccDNA can integrate with the host genome. This is what we refer to as a viral integration with the host DNA. This is a natural process of many viruses. So this integration is basically error prone, and it can induce mutations in the host DNA. And that's what we refer to as insertional mutagenesis. And that's one of the main reasons for development of hepatocellular cancer in reality. So they develop HCC. All right. Clear? They does develop hepatocellular cancer because of this. So these are the reasons why they're going to develop hepatocellular cancer in the first place. So now let us understand the serology. So serology of serology of hepatitis B virus. So what will be the serological findings? Do you understand till now? So whatever I've told you, is there any doubts you want to ask, or I can move on to the serology? Maximum risk of hepatocellular cancer, which phase? There is nothing like hepatocellular cancer as a maximum risk on one of the phases. Hepatocellular cancer can happen equally in all the 4 phases. That's what is very important here to understand. There's no single phase where you can tell HCC risk is very, very high. But even though, I mean, if you want to extrapolate and tell, inflammation is basically going to be there in immune active phase and immune escape phase. This is our interference. This is not given in any textbooks. Our inference is that inflammation maximally happens in immune active phase and immune escape phase. So probably because cirrhosis is very high during the immune escape phase, I can assume that hepatocellular cancer risk will be higher with immune escape phase, but there is no single book which tells you a line like that. This is just our inference. But they just tell the reasons for HCC is either inflammation or interstitial mutagenesis. And once again, it is a typical neat aspirant kind of a question asking the maximum risk always. I know that. I understand your pain. But I don't think nobody will ask you that kind of a question, because HCC can happen at any stage. It's not like it's going to happen only at particular stage. As a clinician, what's important is to monitor for the important thing to know about. What I've told here is you have to monitor for hepatocellular cancer at any chronic HBV patient. That's the take-home point, which means you cannot be relaxed telling that this phase the patient will not have HCC and that phase the patient will have HCC. The idea to know this is the patient will have hepatocellular cancer at any chronic HBV stage, irrespective of the background problem. That is what you need to know. So that is a take-home point. It's not like which is going to have a maximum risk. So we're not going to do anything with that. But if you want to extrapolate and tell, I can tell probably the immune escape phase, because that has the highest chance of developing into cirrhosis, by the way. Anyways, serology. As far as the serology is concerned, we can write hepatitis B surface antigen here. Then I can write hepatitis B DNA, HBV DNA. I can write anti-HBC IgM and anti-HBC total. Anti-HBC total. And we have the hepatitis B E antigen. And we have anti-HBS. That's a surface antigen. And finally, we have the interpretation. So let me talk about the first possibility. So let me talk about HBsAg being positive, HBV DNA being positive, and anti-HBC IgM being positive, and HBC total being positive, HBe antigen being positive, and HBs negative. Very simplest of all things. What is your interpretation of this patient? What is the interpretation here? Come on, I don't want to waste much time. So if you know, you tell no, otherwise you tell you don't know. So what is the interpretation of this? It's an easy one. What is the interpretation here? Yes, this is an acute infection, by the way. This is an acute infection. I don't know what you mean by acute replicating hepatitis, but I don't think there's any term like that, but this is an acute infection, by the way. Okay, all right. So number two, because why it's an acute infection? Because HBsAg positive means always infection is there. And IgM positive means it's an acute infection. IgM can be positive in three situations. One is flare, or it could be acute infection, or probably in the window period. So in window period, of course, everything else will be negative. Only HBC IgM will be positive. But here, you know that both are positive, so it must be an acute infection, of course. So then we are talking about HBsAg being positive, HBV. Maybe I can write like this. So HBsAg being negative, HBV DNA negative, and HBC IgM positive, and HBC total negative, anti-HBeAg negative, anti-HBs negative. So what is the inference here? So here only anti-HBC IgM is positive. What is the inference? They give you a picture like this. Yes, correct. So if you give a picture like this is a window period we are dealing with. Okay, and number three, I can talk about HBsAg negative, HBV DNA negative, and anti-HBC IgM negative, total anti-HBC positive, HBeAg negative, and anti-HBs positive. So what is the inference here? So this is not a chronic infection. So if you want to tell it's a chronic infection, the patient should have HBV DNA positive or HBsAg should be positive. But here the patient is having a resolved infection, which means whenever you get anti-HBs, I clearly told you there are only two possibilities. Either it could be a resolved infection or it could be a vaccinated status, or very rarely it could be an occult HBV infection. But in this condition, because everything else is negative, only anti-HBC is positive, and the anti-HBs is positive, it must be a resolved infection, of course. And anti-HBsAg negative, DNA negative, IgM negative, and HBC negative, HBeAg negative, at anti-HBs alone positive. So what is the inference here? Isolated anti-HBs positivity. Yes, this is a very straightforward, easy one. This is a vaccinated status. Correct. So this is a vaccinated individual. You have isolated anti-HBs positivity. Okay, cool. Number 5, I can tell HBsAg positive, HPV DNA positive, anti-HBC IgM negative, anti-HBC IgG positive, and HBeAg positive or negative doesn't matter, and anti-HBs is negative. So what is this? If you want to know what are they, you can see this and tell. So what is this? SAG positive, DNA positive, IgM negative, total is positive, total anti-HBC is positive, EAG positive or negative, and HBs is negative. Again, there's no need to tell the risk. This patient is having a chronic infection. That's all. This is what I want. So IgM negative, but total anti-HBC positive means that itself tells you it must be either a chronic infection or resolved infections. But here the patient is still having an infection, which means it must be a chronic infection. But what is the definition of chronicity? Whenever in HBsAg, if you want to tell chronicity definition, if the hepatitis B surface antigen persists for more than 6 months, so this is the definition of chronicity according to the textbooks. But in reality, we don't see the chronicity based on persistence of hepatitis B surface antigen more than 6 months. It's just if IgM negative, IgG, total HB and anti-HBC positive, and if HBsAg is positive, we can clearly tell that this patient is having a chronic hepatitis B infection. So this is a chronic infection. Based on that, you can tell, so there are two varieties are there: chronic HBV E antigen positive and chronic HBV E antigen is negative. So based on E antigen positivity and negativity, we can split again into two. One is if ALT is normal and biopsy, liver biopsy showing no hepatitis or only mild hepatitis. So this patient, I can tell this patient is having a chronic inactive hepatitis, E antigen negative. So this is the exact word that will be given in a pathology textbook, but this is what I am going to call it as immune tolerance phase. E antigen positive, chronic inactive, because the ALT is normal and biopsy is not showing any hepatitis. Similarly, if ALT is elevated or if the biopsy is showing moderate to severe hepatitis, I'm going to call this as a chronic active hepatitis, E antigen positive. But this is what we already discussed as something called as an immune active phase, I think, if you remember. So if E antigen is negative, once again, I can split into two based on the ALTs. If ALT levels are normal and biopsy showing no hepatitis or only mild hepatitis, so this group of patients will be called as chronic inactive hepatitis, E antigen negative, but so this is the third classification. And these patients are the ones we called it as immune control phase previously. And if ALT is elevated and biopsy showing moderate to severe hepatitis, these patients are the ones which will be typically in pathology, it will be called as chronic active hepatitis, E antigen negative. This is what we actually called as an immune escape phase. To be honest. So this is how it is. So, using serology, you're going to just tell it's a chronic infection or not. Maybe you can tell chronic infection with E antigen positive or negative, but whether it is active or inactive will be based on the ALT and biopsy. Without ALT and biopsy, you cannot tell whether it's an active hepatitis or an inactive hepatitis. That's all. That's it. So this is a chronic infection. And next, we have the sixth pattern. Where you have this positive, that is anti HBsAg positive, HBV DNA is positive, and HBC IgM is positive, total anti-HBC is positive, and HBe antigen is negative, and anti-HBs is negative as well. So what is this basically? No, this is not a pre-core mutant. No, again, it's not an acute with low infectivity. So this, I can call it as a flare. This is a flare. So this is basically a flare. So what do you mean by a flare? So here anti-HBC total is positive, very likely, which means again anti-HBC IgM is positive. So whenever whenever this is positive, anti-HBC total and HBsAg is positive, very likely it must be a chronic infection, and reappearance of anti-HBC IgM in a patient who's already having a chronic infection is commonly associated with a flare. So this is a patient who's having a flare of a chronic HBV. So I can simply call it as an acute on chronic hepatitis B virus. So this is basically an example of a flare usually. So if HBE is negative, if hepatitis B antigen is negative, so definitely you can think about this particular thing. So usually these patients, if you do anti-HB, they will be positive. Usually they will be anti-HBE positive. So that will clearly tell that is the reason for the disappearance of E antigen here. So I already told you that's why this is a very important point, which I think I mentioned here. The moment they get the seroconversion, I told you multiple times, the moment they get the seroconversion, there is a risk of developing a flare. So very, very important. And the risk of getting acute liver failure is very high during the time of flare. So where is that point I mentioned? Maybe we can go back and see the initial one. Yeah. So if you take this one, that's why I told you this point. So suppose if you see the risk of developing a flare, acute liver failure, one important point I would have told you is seroconversion. Seroconversion during hepatitis B virus carries a high risk of developing a flare. So that's why that point is important to know. So this is something basically you're dealing with a flare. You cannot call acute infection low infectivity because acute infection always means it's a high infectivity. How can you have a low infectivity with acute infection? So HBAG will invariably positive in a acute infection. So this patient is having a flare. There's an acute on chronic hepatitis B virus due to development of anti-HBE. And this anti-HBE is the one that is causing E antigen to be negative. At the same time, that is the one that is actually causing the destruction of the hepatocytes as well. And that is causing the flare. And seventh, HBsAg negative, HBV DNA is positive, but very low titers, not very high titers. And anti-HBC IgM is negative, total anti-HBC is positive. HBe antigen is negative, but anti-HBs is positive. So what is this picture? Yes, this is correct. So only one answer I got it right. So that is occult HBV infection. That's right. So this patient is basically having a occult HBV. So I can rub this off. And this patient is having a occult HBV infection. This is basically an occult HBV. So if you see the overall serology leaving this DNA, it looked like as if they are having a resolved infection, which means anti-HB is positive and anti-HBC total is positive, which means it looks like as if the patient is having a resolved infection. So in resolved infection, you will see these two positive. So it will look like as if the patient is having a resolved infection. But if you see the DNA levels, it might be present at a very low titer. Usually it will be there. DNA will still be positive, still be detected. So that is what we typically refer to something called as an occult HBV infection. So these are the serologies that you need to know, basically, which is very, very important. And apart from that, you can get super infection with hepatitis D virus or co-infection with hepatitis D virus. So what do you mean by super infection with hepatitis D virus and co-infection with hepatitis D virus, and which is going to be a little bit more serious? So that's really important. So on top of that, you can get hepatitis D virus infection. So hepatitis D virus can be either coming as a co-infection or it can be a super infection. Super infection. So usually whenever they are co-infection, so which means HBV and HDV are coming together. HBV and HDV are together. Remember, HDV is very, very rare in India. Usually it is common in the Mediterranean population, especially in the South Europe. So that is where hepatitis D virus is endemic. But apart from that, in India, US, United Kingdom, hepatitis D virus is very, very rare. But suppose if you get hepatitis B virus and hepatitis D virus together, hepatitis D virus increase the risk of chronic HPV. Increase the risk of chronic HPV. So that is what something you need to know. Co-infection. Similarly, whenever they develop super infection, suppose if you have a hepatitis B virus already you are having chronic HPV. So I can write chronic HPV already. On top of that, you have a hepatitis D virus. So this is what we refer to as a super infection. So when you get a super infection, there is increased chance of getting acute liver failure. I mean, even though books call fulminant liver failure, but according to the terminology, fulminant liver failure is just going to mean that the patient is also having acute liver failure. That's all. There is an increased chance that the patient will get a acute liver failure. So increased chance of ALF. That's all. This is something you need to know. So whenever a patient who's having a chronic HBV, so the exam question will be like that. Patient is having a chronic HBV and there is a sudden decompensation indicating the bilirubin is rising and they are getting coagulopathy, encephalopathy and all. So what do you think about? There are two possibilities. One is it could be a flare, that is called as acute on chronic infection, and second it could be a hepatitis D super infection. So there are two possibilities are there. One, it could be a flare, or second it could be hepatitis D virus super infection. So how will you diagnose a flare? Flare means your anti-HBC IgM will become positive most of the time, but anti-HDV IgM will be negative. But if it's a hepatitis D super infection, your anti-HBC IgM will still be negative, but anti-HDV IgM will be positive, which means because it's a super infection, anti-HDV IgM will become positive here because this is fresh. This is coming for the first time. So that's why anti-HDV IgM will be positive here. So if at all they ask you, what is the test that you will do in a patient with a chronic hepatitis B, already a known case of chronic HBV, getting a sudden decompensation, going towards a liver failure, what do you think about a flare or a hepatitis D super infection? So the next test, if they ask you, that you will do is anti-HDV IgM. A chronic HBV patient decompensating suddenly, all of a sudden, think about HDV super infection. So the next investigation that you do is a anti-HDV IgM. Suppose if it's a co-infection, how will you find out it's a co-infection? How will you know it's a co-infection? If it's a co-infection, you will have anti-HDV IgG that will be positive. So that's an indication of a co-infection. But anti-HDV IgM will be negative. IgM will be negative. Both are important. So if it's a co-infection, this will be the case. If it's a super infection, very often they will progress towards ALF. And this is how we identify. HDV IgM will be positive here. So this is called super infection. So this is how you differentiate HDV co-infection or HDV super infection. Remember, the treatment of HDV is the same as that of hepatitis B virus, because once you knock out hepatitis B virus, hepatitis D virus cannot survive. Or if you give vaccination against hepatitis B virus, hepatitis D virus again cannot survive. So that's how you treat or you prevent hepatitis D virus as well. Clear. Now let us put a table. So when will you treat or when will you don't treat? That's the question here. So now coming to the treatment. So now you'll be knowing about the serology. I think serology is now simple. So it's not a very difficult thing. Do you understand the serology so that we can move on to the treatment part? Yes, it's quite clear and simple. That's all. So once we have seen the serology. Let us move on to the treatment part. So once we move on to the treatment, so let us put a small table as for the treatment. So I told you 4 phases. One is the immune tolerance phase, and second is the immune active phase. Then one we have the immune control phase, and we have the immune escape phase, or we can simply write as active phase. Active phase. So in the active phase, you can have either immune active, or it could be immune escape. So both these phases will come under the active phase only, because both are considered to be active hepatitis. In both these conditions, ALT will be elevated, and we have some gray zones also in between. So let us see. So what will be the hepatitis B surface antigen, and what will be the anti-HBC status, the total anti-HBC, and what will be the hepatitis B E antigen status, and what will be the anti-HBE status, and what will be the DNA levels, which is going to be the most important. What will be the biopsy findings, and what will be the ALT levels, and what will be the treatment. So if we talk about immune tolerance phase, we know surface antigen will be positive, anti-HBC will be positive, of course. Either IgM will be positive or total anti-HBC will be positive. HBE antigen will be positive in immune tolerance phase. Anti-HBE will be negative because patient has not yet seroconverted. DNA will be extremely high, usually more than 1 million, which we have discussed already. So, or you can tell, if you want to tell international units, you can tell more than 2 lakh international units also. I can write 200,000 also. So if they ask you how will you convert international units to copies per ml, because many of the times you will be getting the values in international units only, but the standardized one is the international units only, not copies per ml. That's why you need to know this. How will you convert this international units to copies per ml? So usually one international unit is equal to 5.82 copies per ml. So which means 1 unit is equal to around 6 copies, or ideally you can take it as 5 copies also, doesn't matter. So that is why I'm telling, since the number of copies are more than 1 million and the standardized thing is international units per ml and not copies per ml, so I can write it will be more than 200,000 international units. That is 2 lakh international units will be equal to 1 million copies. So more than 200,000 international units per ml will be the DNA values. And biopsy typically will be normal. There will not be any evidence of hepatitis. ALT will be normal because it's immune tolerance phase. And typically you don't need any treatment at all in immune tolerance phase because the liver is not under any threat here. There is no hepatitis going on. In the immune active phase, I mean, it could be escape phase or it could be immune active phase. Nevertheless, anti-HBsAg will be positive, anti-HBC will be positive. HBE antigen can be positive or negative. If it is positive, it is active hepatitis E antigen positive. If it is negative, it is active hepatitis E antigen negative. That's all. Nevertheless, E antigen can be positive or negative. If it is negative, I will be thinking about a pre-core mutant. If it is positive, it's positive. That's all. Anti-HBE can be positive or negative. Usually, if it is initially, it will be negative. Later on, it will become positive. If it is positive, then again in pre-core mutants, it will be positive only. It can be negative or positive, doesn't matter. DNA levels will be more than 20,000. Usually, it will be very high. So if E antigen positive, if E antigen is negative, it will be more than 2,000. I'll come back to that and I'll explain you. Biopsy will definitely show moderate to severe hepatitis. And ALT levels will be definitely elevated. And treatment, definitely, yes, you need to do treatment. Suppose the patient is in immune active phase or immune escape phase, definitely you need to do treatment. Clear. And immune control phase as such, this is basically inactive phase in immune control. This is what we typically call it as inactive phase, where the disease is not active at all. The immunity has controlled full, immunity has gained full control against the virus. So HBsAg will be positive here. Anti-HBC total will be positive because IgG will be positive. HBE antigen will be negative because the anti-HBE will be positive here. There is no doubt. The virus will be clearly suppressed, less than 2,000 copies. And biopsy will be normal. There won't be any evidence of hepatitis. ALT once again will become normal. And once again, you don't need any treatment because liver is again not under any sort of threat here. So how to understand this? So let us go back to the stages and we see. Immune tolerance phase, you don't need any treatment. Nevertheless, don't need treatment because the ALT is normal. And immune control phase, once again, no need treatment because the patient ALT is once again normal. But immune active phase, surely you need treatment because the ALT is elevated, and biopsy will definitely show some sort of hepatitis because of the active immunity, and because it's active, it's going to cause damage. Immune escape, once again, the ALT is high, DNA is proliferating. So definitely this needs treatment for sure. So that's what I am trying to tell here in this kind of table, where immune tolerance phase, you don't need any treatment. And inactive phase, immune control phase, you don't need any treatment. But if it's an immune active or immune escape phase, you definitely need treatment. So that is the idea here. And there could be some gray areas. For example, if you go back here and see, the patient could have this kind of picture. For example, let us assume the patient is having a DNA of more than 20,000. ALT is elevated. Doesn't matter, but DNA levels are suppressed. DNA levels are probably less than 20,000 or less than 20,000. ALT is not elevated that much, less than 2 times the upper limit of normal. So what do you think here? So here the patient might be progressing from immune tolerance phase to immune active phase. That's why the DNA is still high, but ALT is not that high, and DNA is still high, ALT is high, but E antigen is still positive. So you can think about either the patient is moving from this phase to this phase, or patient can be moving from this phase to this phase. You have no idea here. So this is a kind of a gray area that you're dealing with. So which means when they're moving from this phase to this phase, DNA will still can be more than 20,000. ALT levels can be increased, but less than 2 times the upper limit of normal, because the patient is going from active phase to control phase. E antigen can be still positive. So you have no idea. So that's why these are called as something like gray area. And similarly, there is another gray area that you have to look for. 1 second. There's another gray area. Suppose if the patient is moving from control phase to escape phase, you have no idea. For example, here the ALT can be elevated, but DNA can still be suppressed to less than 2000. E antigen can still be negative. Here the DNA is not elevated, but still ALT is elevating. So what is the reason for that? So we have no idea. Either it is the patient is moving from this phase to this phase, that is the reason why ALT is elevating, or is there some other disease that is actually causing the elevation of the DNA, elevation of the ALT, so which we have absolutely no idea here. So that is the reason why. So we have a separate area called a gray zone. So in a gray zone, there will be evidence of chronic hepatitis B, like anti-HBC will be positive and HBsAg will be positive, and HBeAg can be positive or negative, doesn't matter. And HBe will be positive or negative, doesn't matter. And the DNA levels will be highly variable. Biopsy also will be variable here. And ALT can be normal or elevated. But here the treatment will be highly dependent on the biopsy. Suppose if the biopsy shows no hepatitis or only mild hepatitis, you generally don't need any treatment. If the biopsy shows moderate to severe hepatitis, then this patient surely need treatment. So this is the role of biopsy. We have some non-invasive investigations also, which I'll tell you. So here the biopsy shows moderate to severe hepatitis, means you definitely need treatment here. So that is why we have a separate zone called gray area. So not all patients fit into one particular category. So they might have some gray areas in between also. Suppose if the patient is in gray area, if they don't fit into something, so you can typically treat them by doing a biopsy. So that's what they would have given, indications for treatment. Indications for treatment. If you still don't understand, this will help you. Indication for treatment in a chronic hepatitis B virus. The first indication, E antigen positive. Maybe I can write this one, E antigen positive. At the same time, patient is having a DNA of more than 20,000 and ALT elevated more than 2 times the upper limit of normal. So this is a classic example of a immune active phase, if you remember. So this definitely is indication for treatment. Second indication is E antigen is negative, DNA just more than 2000, and ALT is elevated, need not be more than 2 times the upper limit of normal. So this is typically indicating immune escape phase, if you remember. So that becomes an indication for treatment. And the third one, E antigen positive, DNA more than 20,000, ALT is elevated, but it is not significantly elevated. It is less than 2 times the upper limit of normal. So this is a gray zone. This is a gray area. So whether to treat or not. So it depends on biopsy. If biopsy shows moderate to severe hepatitis, then you can treat. So this becomes an indication for treatment. So number 4, if E antigen is negative, DNA is less than 2000, which means DNA is not replicating, but still ALT is elevated, which means we don't know the reason for elevation of ALT here. So if DNA is more than 2000 means it becomes an indication for treatment, but here the DNA is less than 2000. So once again, this becomes a gray area. So I need to do a biopsy. If biopsy shows moderate to severe hepatitis, then it becomes an indication for treatment. So these are the 4 classic indications for treatment in hepatitis B virus and chronic hepatitis B virus. So this is what will be given in the textbooks. So apart from that, there are some other indications for treatment in chronic hepatitis B virus. Suppose if the patient has cirrhosis, irrespective of the stage of chronic HBV, it could be immune tolerance or immune active, doesn't matter. If the patient has evidence of cirrhosis, nodular liver ascites, so definitely it's indication for treatment irrespective of the stage or whatever the phase of chronic HBVs. Second, if the patient is sixth, if the patient is having extra hepatic manifestations of hepatitis B virus, like glomerulonephritis, polyarteritis nodosa, if there is some extrahepatic manifestations, surely the patient should be treated irrespective of the stage of the disease. Number 7, the patient is pregnant. You have to definitely treat. This treatment in pregnancy is to decrease the vertical transmission. To decrease vertical transmission, you can treat a pregnant individual. But apart from that, there is no much indication for therapy. So these are the usual indications for treatment in a hepatitis B virus. But remember, irrespective of the stage of hepatitis B virus, if these indications are there, you need to treat the patient. So in pregnancy, you treat to decrease the vertical transmission, not to treat the pregnant mother. That is to prevent the vertical transmission. That is the idea of treating a pregnant mother in the first place. So these are the clear-cut classic indications. So I can rub this off because this is something not should be written here. So as I told you previously, if it's a clear-cut indication, if you have a clear-cut immune active phase or immune control, immune escape phase, you have to treat. But if there is any gray area, then you take a biopsy and decide on the treatment. So that's one thing you need to know. And apart from that, there is something called monitoring of hepatocellular cancer. So I told you, I think Pranavi asked this question previously, which says the maximum risk of developing HCC. I told you that is not a valid question because every single stage or any chronic HBV patient, they got cirrhosis, they didn't get cirrhosis, doesn't matter. They always have a risk of hepatocellular cancer. So that is the reason why any hepatitis B virus patient, plus whatever may be the stage, this should be the gold standard point. I can write separately here, any hepatitis B virus patient, any chronic HBV patient, irrespective of the stage, should be monitored for hepatocellular cancer. Currently, what is the monitoring method? Monitoring method is doing alpha fetoprotein and ultrasound. Every 3 to 6 monthly, we do this to monitor for hepatocellular cancer. But all patients with chronic HBV, irrespective of the stage of the disease, irrespective of the status of cirrhosis, whatever may be the case, you have to monitor that patient for development of hepatocellular cancer, because they can develop hepatocellular cancer at any stage. So that's the idea here. You have to do 3 to 6 monthly alpha fetoprotein and ultrasound for monitoring hepatocellular cancer. Okay, so now you know the indications for treatment. So what are the options for treatment? So which means, what are the treatment options? What are the drugs that you can use? So you have 2 groups of drugs. One is called oral drugs and second one is parenteral drugs, which you can use. As far as oral drugs are concerned, these are the first line drugs, basically. Oral. Parenteral we don't use nowadays, we use very sparingly. Parenteral, only one is there, that is pegylated interferon alpha. Typically you have 2, one is called interferon alpha 2A and second is interferon alpha 2B. 2A is most commonly used, but 2B is used only if the patient is having hepatitis B virus and hepatitis D virus infection together. So apart from that, we don't use 2B, we use 2A only very commonly. So pegylated interferon alpha 2A. So there are some indicators where you can use pegylated interferon alpha, but even though we don't use them nowadays because it has to be given subcutaneously and it has a little bit of side effects, to be honest, and there are some contraindications also. So side effects, most common side effect, if they ask you, it will be flu-like reactions. That's going to be the most common side effect for peg interferon alpha 2, any interferons. As far as the contraindications are concerned, pregnancy is a contraindication. Then patients who are having cytopenias, low WBC count, low platelet count, so that's going to be a contraindication. And apart from that, patients who are having decompensated cirrhosis, like high bilirubin, and the patients who are having high PTNR. So decompensated cirrhosis is definitely a contraindication. You can remember like patient with a heart failure, or you can remember as a cardiac failure. Cardiac failure is a relative contraindication. So usually I need to call it as 4C. 4C, the first C stands for a patient who is carrying cytopenic cirrhosis, cardiac failure. So this is how I remember 4Cs. Patient who is carrying the pregnant, cytopenic, decompensated cirrhosis, and cardiac failure. These are the 4 basic contraindications for interferon alpha 2A. So, but there are have some advantages. Advantages, which means it's given for only finite duration, which means you cannot give for indefinite duration. Finite duration typically only 48 weeks. You cannot give beyond that. And there is no resistance shown to interferon still now by the virus. And they have higher chance of seroconversion compared to oral drugs. Because I told you the primary reason why you give this interferon alpha or any treatment for that matters is to seroconvert. So, and what are the things that will tell you interferon alpha will be a better option in certain patients? For example, very young, who's having no cirrhosis, non-cirrhotic, they're having a low DNA but a very high ALT count, very high ALT but a low DNA, not a very high DNA. And if they have favorable genotype in the sense A, B, C, D last. So D is considered to be very unfavorable genotype. Because D is very common in India, usually interferon alpha is out of the question in India, because D is not a favorable genotype for interferon alpha use. So interferon alpha is better if the patient is young, without cirrhosis, low DNA with a high ALT, and having a favorable genotype, especially A genotype. A for America. A genotype is very common in US. So there some gastroenterologists use interferon alpha because the genotype A is very common. But in India, it's completely out of the question because that's considered to be unfavorable genotype for the response to interferon alpha. As far as oral drugs are concerned, we have 2 groups of drugs. One is called nucleoside analogs, and second one is nucleotide analogs. The best example and the most effective drug available under this nucleoside analog is entecavir. Entecavir is the most potent drug available right now. The dose is 0.5 to 1 milligram once a day. So usually we use a standard dose of 1 milligram. Suppose the patient is having a cirrhosis, we prefer a dose of 0.5 milligram. That's all. But the dose is 0.5 to 1 milligram per day. Once a day dose, very, very good drug. And in the nucleotide analogs, we have tenofovir. Tenofovir is a very good drug. And we have 2 components. One is called tenofovir disoproxil fumarate, and second one is tenofovir alafenamide. The standard dose of disoproxil fumarate is 300 milligram per day, and for alafenamide is 25 milligram per day. The advantage of alafenamide is it's a pro drug, as you need to give a lesser dose, and the risk of nephrotoxicity with alafenamide is quite less compared to tenofovir disoproxil fumarate. But whatever may be the fact, the side effects of tenofovir is the fact that they are nephrotoxic. They can reduce the bone density because they can produce Fanconi-like syndrome. Fanconi syndrome in the sense they will have this phosphaturia, glycosuria, amino aciduria. We have already discussed in the RTA section. They can develop Fanconi syndrome. And of course, they might have a reduced bone density. They can cause reduced bone density. These are the side effects of tenofovir, by the way. But more importantly, you need to know about alafenamide is a little bit better, less nephrotoxic, but it's very costly. What is the side effect of entecavir? Entecavir is one of the very well tolerated drugs. The only known side effect is lactic acidosis because of mitochondrial toxicity, but that's extremely rare. Apart from that, there is no known side effects of entecavir. There are other drugs in this group. For example, for nucleoside analogs, we have lamivudine and we have telbivudine. So these are other drugs which are less potent drugs, not used very commonly nowadays. And nucleotide analogs, we have like tenofovir, we have adifovir. You can remember, lamivudine and telbivudine will come under nucleoside analogs, and adifovir and tenofovir will come under nucleotide analogs. But remember, tenofovir and entecavir are the commonly used drugs. We don't use lamivudine, telbivudine or adifovir very commonly, and only in very resistant cases in certain situations we can use as a combination. But apart from that, entecavir and tenofovir are the ones that are usually preferred. So what are the advantages? Advantages of oral drugs: they are not going to have much of side effects, which means they are safe and very, very effective. And in fact, they are safe in pregnancy also. If they ask you which is the drug that you will prefer in pregnancy, answer is tenofovir. Tenofovir is considered to be absolutely safe in pregnancy. In pregnancy, what you use is tenofovir only. and they are oral drugs. Big advantage, patient need not get injected, and you can use in cirrhosis. At the same time, you can use in HIV co-infected patients also. In HIV co-infection, if they ask you what are the drugs that can be used, typically the TEL group of drugs is what we can use. We have tenofovir, we have emtricitabine, and we have lamivudine. So these are the drugs that can be given in patients who are having HIV and hepatitis B co-infection. Of course, the best drug will be tenofovir only, but most of the times we use a combination of these drugs. So whenever the patient is having HIV and HBV co-infection, this is the regimen that we are going to use, TEL. So these are the 3 drugs that will be effective in HIV, HBV co-infection: tenofovir, emtricitabine, and lamivudine. And emtricitabine does have some effect against hepatitis B virus also. So it can be used in HIV and HBV co-infection. Okay. Fine. So what are the disadvantages? Disadvantages of these oral drugs. Number 1, it cannot eradicate. Very difficult to eradicate the virus based on these drugs, and there will be reduced rates of seroconversion compared to that of the interferon. So most of the times you need a very prolonged treatment. You need a very prolonged treatment with oral drugs. And at the same time, there is a potential for drug resistance till now, but we don't have any drug resistance. Entecavir has shown resistance in some areas, but tenofovir right now, till now, you don't have any resistance for tenofovir, but still there can be a potential drug resistance that can happen. So for oral drugs, there should be an endpoint for giving oral drugs. So which means how long you will give oral drugs is a question. So which means you cannot give indefinitely or you cannot give for a definite period. So you need to have some endpoints. If they ask you the best endpoint is surface antigen should become negative. Till the surface antigen becomes negative and anti-HBs becomes positive, you need to give the drugs. This is the best endpoint for any oral drug, which means till you eradicate the virus. So that is the, eradication evidence is surface antigen should become negative and anti-HBs should become positive. This is the time where, till the time where you have to give the oral drugs. But technically speaking, theoretical, not practical indicators are there. So this is the best indicator, but we have some practical endpoints. So what are the practical endpoints? Practical endpoints, suppose if the patient is E antigen positive, if at the beginning of your therapy, if the patient is E antigen positive, you're going to give till the patient becomes E antigen negative. This is what we refer to as seroconversion. As I told you, seroconversion is a very important, factor in determining the treatment of hepatitis B virus also. You have to give till the patient becomes E antigen negative, plus you have to give 6 to 12 months as a consolidation therapy. So till the patient becomes E antigen negative, plus you have to give 6 to 12 months as a consolidation therapy. Suppose if the patient is E antigen negative by the time you are starting this treatment, then practically you have to give indefinitely. Indefinitely in the sense the patient should become S antigen negative and anti-HBs positive. Till that you have to give the therapy. So these are the practical endpoints. These are very important questions for exam. So number 1, if the patient is E antigen positive, you have to give till the E antigen becomes negative plus 6 to 12 months as a consolidation therapy. If the patient is E antigen negative, then your treatment will become practically indefinite. So that is the most important thing. Okay. So then there are some special things that you need to know about hepatitis B virus. One is the treatment that you're going to follow in pregnant individuals. And next is the vaccination. So what you're going to do in the vaccination of hepatitis B. So as far as treatment in pregnant individuals is concerned, in pregnancy. So first of all, when you're encountering a mother with HBsAg positive, you need to know the risk of vertical transmission. Risk of vertical transmission, if E antigen is positive, as I told you previously, risk is 70 to 90%. If the patient is E antigen negative, then the risk is approximately 10 to 30%. So first thing that you need to do is achieve a seroconversion. That is, E antigen should become negative if the patient is E antigen positive already. So all S antigen positive mothers should be treated. That is to reduce the risk of vertical transmission, number 1. So treatment should be directed for the mother and treatment should be directed for the child as well. So mother is optional. Mother you can treat or you not treat, but child is definite. Definite treatment is required for the child. So child treatment is very, very important, which means you will be treating in the neonatal period itself. So what is the treatment available for the child? As soon as the child is born, you are going to give hepatitis B immunoglobulin. The dose is same 0.02 ml per kilogram. Approximately, you will give a dose of 0.5 ml of intramuscular injection of hepatitis B immunoglobulin. Plus, you have to initiate the hepatitis B vaccine series. First dose of vaccine should be given, and both these things should be done within 12 hours of birth. This is the most important treatment. So whether you treat the mother or not is secondary, but the most important treatment is for the neonat. This will reduce the risk of the child becoming infected with hepatitis B virus to a substantially great level, to less than 3%. That's why this is a very, very important part of therapy. Mother is optional. You can start with antiviral. Typically, we start with tenofovir, typically at 3rd trimester. Especially, the most important indication is if DNA levels are very high. DNA levels are 200,000 international units per ml. At very high DNA levels, there is a high risk of vertical transmission. So mother is optional. You can give TDF, especially at 3rd trimester, and especially if DNA levels are more than 200,000 international units per ml. That is more than 1 million copies, 10 lakh copies per ml. So in that situation, you can treat the mother with tenofovir disoproxil fumarate, TDF, or tenofovir alafenamide. Tenofovir is the best drug for treating hepatitis B mothers in pregnancy. But the neonatal treatment is 100% should be given. That should never be deferred at any cost. So you have to give hepatitis B immunoglobulin, 0.5 ml IM, as soon as they are born, plus hepatitis B vaccine immediately as soon as they are born, preferably within 12 hours. But I'll tell you ASAP, as soon as possible, it's better to give. So this is how you treat a pregnant mother and a neonat who is supposed to get hepatitis B virus to prevent the vertical transmission and perinatal transmission. And now coming to the vaccine, because there will be something they'll be asking you about the vaccination data, because there are a lot of things that have changed in the recent times for the vaccination. So what are things that you need to know about the vaccine? Number one, you need to know about the course of vaccine. Typically, we have to give 3 doses. The standard course that we follow is 0, 1, 6 months. So this is the course we follow for vaccine. 3 doses are enough. So immunity is achieved in more than 95% of the individuals, which means you don't really need to check the anti-HBs in majority. But if you want to check the response to immunity, suppose if you want, but most of them, as a rule, we don't check the response, because otherwise it will be extremely costly from the government point of view to check anti-HBs for everyone. But you can check anti-HBs for patients who are at high risk, for healthcare workers, and patients who are at risk of becoming a non-responder, like patients who are on dialysis, CKD patients, and patients who are HIV patients, or patients who are on immunosuppressive therapy like chemotherapy, or post-transplant individuals. So patients who are at risk of becoming a non-responder, like hemodialysis, HIV, or immunosuppressed individuals, or patients who are having ongoing risk, like healthcare workers, who definitely needs to check the response. So this is the usual indication for checking the response. Otherwise, in the general public, we don't check the response, because it is effective in more than 95%. Who are at risk of non-response, which means non-responders, only 3 patients: hemodialysis patients, HIV patients, and immunosuppressed individuals, like post-chemotherapy or post-transplant patients. And second thing is patients with ongoing risk, like healthcare workers. So these are 2 indications for checking the response. Otherwise, we don't check. So how to check the response? Typically, you check the anti-HBs values. Usually, you will be checking at 1 to 2 months post completion of vaccination. Remember, only after complete vaccine series, you need to check the response. Anti-HBs typically will be doing at 4 to 8 weeks. That is 1 to 2 months after the completion of the vaccine. So if the levels are more than or equal to 10 international units per ml, then this is typically a responder. If the levels are less than 10 international units per ml, then we call them as non-responders. So this is a definition of a non-responder. If it's a responder, suppose if it's an immunocompetent individual, there is no further need for repeat anti-HBs checking at any point in their life. And second is, there is no further need for a booster. There's no need to give booster. So this is something which is very important, and that has come in the recent times. So no need for a booster injection, because they will be asking whether you need a booster or not. Suppose the patient is immunocompetent individual, once you know it is anti-HBs is more than 10 at any point in their lifetime, there is no need to check anti-HBs again. There is no need for a booster. But many individuals do ask me that initially it was more than 10, but later on if they check after maybe 5 years or 10 years it has become less than 10. Do I need to worry? Again, if the patient is immunocompetent, which means there is no known immunosuppressed, no risk of immunosuppression, even if the values are less than 10, after initial value of more than 10, you need not worry, because next time when you encounter an antigen, it could be an anamnestic response. The values can be less than 10, but once you encounter the virus next time, you will produce a anamnestic response and your antibodies will increase and you will clear off the virus. So no need to worry about that. So once if you prove that the levels are more than 10, once it's enough, after that you need not check, especially in immunocompetent individual. So only in selected patients, suppose if the patient is immunosuppressed or if the patient is having a chronic hemodialysis, CKD patients, you might need to test annually. Repeat testing is recommended every year for them. Only if the patient is immunosuppressed, otherwise no needed. At any point of time in annual testing, if anti-HBs is less than 10, then you can give a single booster. So which means there are only selected group of patients where booster is indicated. So those patients where anti-HBs becomes less than 10, plus if the patient is having a high risk, like immunosuppressed or chronic hemodialysis, these are the patients, only patients who will be requiring a booster. So ideally you don't need a booster otherwise. So even if the values are less than 10, if you're immunocompetent, initially you demonstrate a value of more than 10, even after 5-10 years, you become less than 10. If you are immunocompetent, there is no need for a booster and there is no need to repeat anti-HBs at all. So once if you have proved anti-HBs is more than 10, that's enough. Only if the patient is immunosuppressed or going for a chronic hemodialysis, you need to check one more time. Otherwise you don't need. So if it's a non-responder means here you don't need to give a booster. You need to give a second full course of vaccination. Full course of vaccine. So now they can be either a responder now, or now they can be a non-responder. So once, even after the second course of vaccine, if they still remain a non-responder, that is anti-HBs less than 10 persistently after 2 courses, there are 2 things that you need to know. You need to know. One is always rule out a chronic HBV, chronic hepatitis B virus. So please understand, in chronic HBV infection, where is the table in a chronic HBV infection, you won't develop an anti-HBs. How many ever times you give vaccine, you won't develop an anti-HBs. So if they do not develop anti-HBs, after giving 2 courses of vaccination, the first thing to rule out is a chronic HBV. So in chronic HBV, you will never develop an anti-HBs. If you develop anti-HBs, you will become a resolved infection. That's a protective antibody. So in chronic HBV, you don't develop anti-HBs. And that is why it's called a chronic HBV. You cannot develop because your immunity is low. Second thing what you need to do is, if once you have ruled out a chronic HBV, there is no need of any further vaccine. There's no need of any further vaccination. There's no need. Of course, there's no need of further vaccine because 2 times no response to vaccine. So why you need it? So here, this is the latest to the latest idea about the vaccination. Remember, the first thing that you need to know is general public vaccine, send them off. That's all. No need to check anti-HBs because it's effective in more than 95%. It's only need to check and waste the resources. Second point that you need to know is, if you're a healthcare worker or if you are a patient who's having risk of immunosuppression like hemodialysis or HIV or chemotherapy, then you can check anti-HBs. So that's the only reason why you check anti-HBs. If you have checked anti-HBs, if it's more than 10, you have proved that. If you're a healthcare worker and if you are remaining immunocompetent, there is no need for any booster further and there is no need for any repeat anti-HBs check. Even if anti-HBs becomes less than 10 later, don't need to worry. If you're immunocompetent, you will produce an anamnestic response to injection of the virus. Next, if you're an immunosuppressed individual or if you are going for a chronic hemodialysis, then probably you might be needing to check anti-HBs every year. So then if the anti-HBs becomes less than 10 at some point of life, then probably you might think about giving a single booster. That's enough. Similarly, non-responders, at first anti-HBs check itself, it is less than 10. So those individuals should go for a second course of vaccine. If second course of vaccine is also not effective and if they cannot mount an anti-HBs response, then first thing to rule out is a chronic HBV. And once you rule out chronic HBV, you can be sure that there is no need of any further vaccine because 2 times they are non-responder means they will remain non-responders how many ever times you are going to give the vaccine. So that's the idea. Next thing is the post-exposure prophylaxis. The PEP is what you're going to try and learn. So what is the thing post-exposure prophylaxis, which means you have encountered needle stick injury or probably through some other route you have encountered hepatitis B virus. So first thing in a PEP is to know the source, whether it's positive or negative. So if the source is anti-HBsAg positive, or if the source cannot be tested, the source cannot be tested, untestable source, or if the source is HBsAg negative. Remember, if the source is HBsAg negative, no treatment is required, no PEP is required. You can just send them off. So if the person who has got exposed is not vaccinated, then you can initiate a vaccine series. The vaccination should be universal. Apart from that, there is generally no treatment needed. If the patient who has got exposed is not vaccinated yet, you can start vaccinating them. So now see the vaccination status of the exposed person. If the source is HBsAg positive, or if the source is untestable, then see the vaccination status of the exposed individual who has got exposed to the needle stick. And if the vaccinated individual is, if you are encountering a completely fully vaccinated individual, or it could be an unvaccinated individual, or you might encounter a person who is undergoing vaccination. Remember, if the patient is vaccinated, now you need to know whether it's a known responder or whether it's a known non-responder, or number 3, antibody response is unknown, which means they have never checked the antibodies in the past. So if the patient is a known if the exposed individual is a known responder, no further treatment is required, which means already they have been demonstrated once that anti-HBs is more than 10. So no need to check again. I clearly told you. If a known non-responder means, then here you will give HB immunoglobulin, hepatitis B immunoglobulin, plus you have to reinitiate vaccination series. This is option number 1. Or second option is you can give hepatitis B immunoglobulin into 2 doses. If already, if already completed 2 courses of vaccination, already 2 vaccine series has been done, but still they are non-responders, means there's no need to give another vaccine, because I told you how many ever times you give, there is no point. If they received only 1 vaccine course and they are non-responders, means reinitiate vaccine 1 more time. If they've already received 2 vaccine series and still they are non-responders, means just give 2 doses of hepatitis B immunoglobulin. That's enough. If antibody response is unknown, but they have completed the vaccine series, then immediately initiate a booster. Plus, you are going to recheck the anti-HBs. So if anti-HBs is more than 10, then no further treatment is required. If anti-HBs is going to be less than 10, which means here you are going to treat like how you have treated a non-responder. Treatment like a non-responder. That's all. So how you have treated a non-responder, you're going to treat like that. So while giving the booster, recheck anti-HBs. If it's more than 10, no further treatment is required. Just the booster alone is enough. If it's less than or equal to 10, then you're going to treat like a non-responder only. How you have treated a non-responder, the same algorithm you will be following for these individuals. Then what are you going to do for unvaccinated individuals? Unvaccinated means it includes partially vaccinated, like they have received only 1 course, but they have not completed the vaccine, and it's been years together since they have did that first course, so are partially vaccinated. So these individuals should be deemed as unvaccinated only. So you will give hepatitis B immunoglobulin, plus you have to give a vaccine series, complete vaccine series. It's very simple. Suppose if the patient is undergoing vaccination, suppose I have completed 1 dose, I'm due for the 2nd dose, or I have completed this 2 doses, I'm due for the 3rd dose. By the time I got a needle stick injury, then I'll be just giving hepatitis B immunoglobulin, plus you just need to complete the vaccine series. That's all. Complete the vaccine series. Here, writing complete is, I can write mostly reinitiate vaccine series. Probably initiate vaccine series will be the right statement here. You're going to initiate vaccine series, you have to complete it, because the patient is already undergoing vaccinations. You're going to complete the vaccine series. That's the idea here. That's all. So it's quite simple. So, everything is based on a single principle that previously I told you. So in immunocompetent individual, there is no need to check repeat anti-HBs, and there is no need for a booster also. No need for further booster. Same thing. Suppose, let me recap you once again. If the source is HBsAg negative, then no need to do anything. If the source is HBsAg positive, or if the source is untestable, then see the vaccination status of the exposed individual. If the exposed individual is fully vaccinated, then you need to know the response status. If the patient is a known responder, then no further treatment is required. If the patient is a known non-responder, then depending on how many vaccine series they have been got in the past, that will tell you how much hepatitis B immunoglobulin doses you need to get. The patient has got only one vaccine series and they are a known non-responder, then you can give one dose of hepatitis B immunoglobulin and give one more HB vaccine series. If the patient already received 2 courses of vaccine, still they are non-responders, means there's no point in giving any further HBV vaccine, and just give 2 doses of hepatitis B immunoglobulin. And if the patient is antibody response is unknown, then immediately initiate a booster and recheck anti-HBs levels. If it's less than 10, treat like a non-responder. If it's more than 10, then no further treatment is required. The patient is an unvaccinated individual or partially vaccinated years ago, they have not completed the vaccine series, treat like an unvaccinated individual only. You are going to give immunoglobulin and HBV vaccine with a full course, 016. The patient is undergoing vaccination right now, so you're going to give a hepatitis B immunoglobulin and just complete the vaccine series. Whatever they are going, whatever the doses are due for now, complete that vaccine series. That is enough. So this is how you manage a post-exposure prophylaxis. And what is the dose of hepatitis B immunoglobulin? HB immunoglobulin in neonates, I told you 0.5 ml is the standard dose, but here I'm going to use 0.04 to 0.07 ml per kilogram. But most importantly, hepatitis B immunoglobulin should be given at a site that is where you don't give the vaccine. Vaccine and hepatitis B immunoglobulin should be given at a different sites. Otherwise, like that immunoglobulin will neutralize the vaccine strains. So there's no point in giving at the same site. So you have to give one deltoid. Vaccine should be given in one site. Immunoglobulin should be given in another site. At different sites you have to give, which is a very important question in exams as well. And I think that completes our discussion on hepatitis B virus, which is a very important and very interesting one, hepatitis B virus as such. So I think we have discussed in so much of detail on hepatitis B virus, right from the natural history, then we talked about the genome, then we talked about what you mean by hostile antigen and DNA particle, then we talked about the different genotypes and the serotypes, and then we talked about the replication inside the cell, then we talked about the immunopathogenesis, then about the different serological markers and the different stages of a chronic HBV infection, and what are the serology and how to find out, interpret the serology, and what do you mean by HDV co-infection, superinfection. Then what are the indications for treatment, and what are the non-indications for therapy, and what are the drugs that you can use, parental and oral drugs. Oral drugs are the commonly used drugs in India, and what are the advantages or disadvantages of each, and what are the endpoints of oral drugs, and how to treat HBV in pregnancy, and what is the idea of giving a vaccine, and how to manage a patient who has been exposed to a needle stick like a healthcare worker using a post-exposure prophylaxis. And one more final point that you need to know is the fact that in pregnant mothers, in pregnant mothers, hepatitis B does not form an indication for LSCS. Patient does not need a LSCS, number one. And it's not a contraindication for breastfeeding. Breastfeeding is not contraindicated, which means for the sake of hepatitis B virus, there is no need to do LSCS. That's number one point. So that's not been shown to improve any outcome. And similarly, breastfeeding can be done even if the mother is hepatitis B positive. So breastfeeding is not contraindicated. And for HIV, under selected situations, LSCS is indicated and breastfeeding may be stopped in certain situations. But as far as hepatitis B is concerned, LSCS need not be done as a sole reason because the patient is hepatitis B virus positive. And second thing, breastfeeding is not contraindicated as well. Clear? If HBV presents as ALF, what is the chance of it persisting as a chronic HBV? Very, very, very less. So if the patient is having acute liver failure, what is that? The chance of having chronic HBV is very, very less. Most of them will be recovering. Most of them, almost 100%. First of all, you have to recover. In fact, most of them will be recover. So most of them will be recovering, and almost 100% these patients will clear off the infection. So as far as the ALF is concerned. So usually it's very rare. But if you want to really tell, the same rule will apply depending on the age. So if the ALF happens in adults, then very likely they will clear off the virus. If the ALF happens in children, probably the patient can and develop a chronic carrier state. But in general, ALF, moving to chronicity is very, very rare. So once they get ALF, they clear off the virus most often. But it's all about ALF, that they have to recover from the ALF first. If a chronic HBV patient gets an ALF, that is different. Ankit is asking HBV presents as ALF. HBV presenting as ALF, there are two possibilities are there. In fact, three is there. Either an acute infection presenting as ALF, which is quite rare, number one. Even if they present, most of them will clear off the infection. Second possibility is a chronic HBV presenting as ALF, and that will happen in two situations. One, either it could be a flare that can happen at the time of spontaneous seroconversion, which I've told you, or second possibility is a chronic HBV patient getting a HDV superinfection, which can progress towards ALF. So each and every scenario will be managed differently. So either you're talking about acute HBV coming with ALF or a chronic HBV coming with ALF, will sort out the debate. So acute HBV coming with ALF mostly will recover, no problem, clear off the virus. Chronic HBV coming with ALF, you have to think about whether it's a flare or whether it's a superinfection. Flare is extremely common at the time of seroconversion, spontaneous, not drug-induced seroconversion. And chronic HBV coming as ALF, second important reason is you think about a HDV superinfection. So as I told you how to find out HDV superinfection, we have discussed already. Do you understand this? So HBV is quite simple. So it's so simple and very easy also to understand. Not a very difficult task to understand at all. It's a very interesting infection as well. Do you understand, so that we can move on to the next? Okay, if you don't have any further questions, we can move on to hepatitis C virus. No further questions, right? Okay. And hepatitis C virus as such is quite simple. It's not very difficult to understand hepatitis C virus, by the way. As far as hepatitis C virus is concerned, the highest risk of chronicity, carrier state, cirrhosis, HCC, and in fact, most common cause of liver transplantation in the world is hepatitis C virus only. Even though we don't have data from India, but the most common cause of liver transplant, orthotopic liver transplantation in the world right now is hepatitis C virus. So it's one of the high risk virus that causes chronicity and carrier state. And there are quite a few areas that they'll be asking you with regards to hepatitis C virus. And hepatitis C virus is basically belongs to the flavivirus group. Number one, it's an RNA virus, which carries an RNA polymerase. It's an RNA virus and it contains the basic RNA polymerase in it. And the genotype is really, really important as far as hepatitis C virus is concerned. Very important for hepatitis C virus. Compared to hepatitis B virus, hepatitis C virus, the genotype is really, really important. So in fact, the treatment is dependent on the genotype only. Treatment is dependent on the genotype of hepatitis C virus. So that's why the genotyping is more important. And in fact, the characteristic, virulence, characteristic features, the disease characteristics, all these things will be based on the genotype only. So that's why the genotype is very, very important as far as hepatitis C virus is concerned. For B virus, A virus, E virus, genotype, even though we learned, but it is not important. But for C virus, genotyping is really, really, really important. Number one. And at the same time, the risk of chronicity is extremely high. Almost 60 to 80% of all patients who get HCV will develop chronicity. There are multiple places where you can get, the natural history of hepatitis C virus is very easy. So for example, when you talk about natural history of hepatitis C virus can come as subclinical infection, which is the most common way, or they can come as acute hepatitis, which is rare. Acute hepatitis only in approximately like maybe 10 to 15% of the patients will come with acute hepatitis. And once again, this acute hepatitis that is seen due to hepatitis C virus cannot be differentiated from acute hepatitis due to other viruses. A, E, B, everything will resemble the same. You cannot separate it out. And most of the patients most of the patients with acute hepatitis will enter the chronicity. Here, they are also not spared. Majority will enter chronicity. Very few who are getting acute hepatitis may recover, which means they may clear off the virus. But remember, there is one thing that does not happen in hepatitis C virus is the ALF. Acute liver failure is something a very, very uncommon finding in hepatitis C virus. And most of the patients who get a subclinical infection also will end up with chronicity. Almost everyone. Almost majority and everyone who end up with a subclinical infection will end up with a chronicity. Very, very small amount. Few patients, very minor amount of patients, like 5%, 4% can recover or they can clear off the infection. And which means, like any patient who got a hepatitis C virus, whether it's a subclinical infection or whether they got acute hepatitis, always carries a risk of chronicity. So chronicity is something that's extremely common. And once they get chronicity, there is a high chance of going for chronic liver disease. There is high chance of going for, first it should be chronic hepatitis, isn't it? There is a high chance of going for chronic hepatitis. There's a high chance of going for chronic liver disease. There's a high chance of going for cirrhosis and possibly even hepatocellular cancer. Very, very high risk. So which means most of the patients who get hepatitis C virus will end up with chronicity. That's the idea. Whether they get acute hepatitis or whether they get subclinical infection doesn't matter. They end up with chronicity, and from chronicity by around 25 to 30 years, they will end up with cirrhosis or hepatocellular cancer for sure. So that is a take-home point here. So that is why most of the patients with hepatitis C virus has to be treated. There is no particular indication like this patient has to be treated and this patient should not be treated. But nevertheless, there is a definition of chronicity. How will you define chronic HCV? How will you define a chronic HCV? So I told you the definition of chronic HBV, that if hepatitis B virus is persisting in the body for more than 6 months. So surface antigen more than 6 months. If it's positive, it's called chronic HBV. But for chronic HCV, it's the RNA. Suppose if HCV RNA, if it's persisting for more than 3 months, that is 12 weeks, that is defined as chronicity. That is the definition of chronicity. So 3 months is the cutoff here. The persistence of HCV RNA beyond 3 months is the definition of chronicity. For HBV, it is the percent of surface antigen beyond 6 months is the definition of chronicity. For HCV, it is the percent of HCV RNA beyond 3 months or 12 weeks is the definition of chronicity. So how do you treat them? In fact, almost all patients will be treated. So there is only 2 tests that are available for diagnosis. One is the anti-HCV, that is the total anti-HCV. Right now, we don't have any IgM test for anti-HCV. And second is HCV RNA. These are the 2 investigations that are available. Based on this, how can we interpret? So let us assume anti-HCV and HCV RNA side by side. If anti-HCV is positive, HCV RNA is negative, which means the patient is having only a remote infection, which means the patient has recovered from the infection. Anti-HCV positive, HCV RNA is also positive, then this patient is having active infection. That's all. If both are negative, then very likely the patient is having a no infection. No evidence of remote or active infection. Remote or active infection. But remember, right now we don't have anti-HCV IgM, even though many labs are trying to find out a way to find out anti-HCV IgM. But right now we have only total anti-HCV and HCV RNA. These are the commonly used things. So typically this is what we think about. So whenever anti-HCV RNA is positive, then only you can call it as an active infection. Otherwise, you don't call it as anti-active infection. So basically, screening wise for diagnosis. So whenever a patient is having anti-HCV positive, if they ask you the next step, what you will do, next step is you have to do HCV RNA. So if HCV RNA is negative, I'm going to tell the patient is having a remote infection. So if HCV RNA is negative, anti-HCV is negative, then it will be definitely no infection. I'm not going to evaluate further. If anti-HCV is positive, then I'll be thinking about, I can write here, isn't it? If anti-HCV is positive, then I can do a next step is HCV RNA. If HCV RNA is also positive, then definitely the patient is having active infection. Ideally speaking, you need to wait for 3 months and repeat HCV RNA and prove that the patient is having chronic infection. But any active infection patient, it's better to start the treatment. But before starting the treatment, it's very, very important that you need to know the genotype. Genotype assays are very, very important. So find out the genotype, because the treatment of hepatitis C virus is based on the genotype. So it's genotype based, which means one more time I will take the sample. So once I know it's HCV RNA positive, ideally what I should do is I should do the genotype assay. Once I know the genotype, then only I will initiate the treatment. So this is a standard rule. Anti-HCV positive, then see HCV RNA positive. It must be active infection before starting the treatment. Do the genotype assay. Once you know the genotype, then you are going to initiate the treatment. Because once again, I'm telling you, HCV treatment is genotype based. But we are talking about genotypes here. What is the most common genotype in India? So in India, if they ask you what is the most common genotype, it's the genotype 3. In the 3 itself, there is something called 3A that's going to be very common in India. So what are the peculiarities of genotype 3? In fact, this is discussed in many of the world conferences itself. There are some basic peculiarities of genotype 3A. Genotype 3A is known to cause excessive amounts of steatosis, too much steatosis. And one of the important reasons for getting a fatty liver is hepatitis C virus. There are many differential diagnoses of fatty liver. Not only the non-alcoholic fatty liver disease. There are so many differential diagnoses of fatty liver. One of the important differential diagnoses for getting a fatty liver is your hepatitis C virus. In that, the genotype 3A is the one that causes maximum amount of steatosis and maximum amount of steatohepatitis as well. Rather than causing cytopathic damage, this causes, apart from causing this cytopathic effect on the hepatocytes, this steatosis itself causes a lot of damage to the hepatocytes. So it causes too much of steatosis. That accumulation of fat is very characteristic of genotype 3A, and that is the genotype that is common in India as well. That's why genotype 3A will have a completely separate treatment. And the algorithms of how you treat different genotypes is beyond the scope of the current discussion. But still, the drugs that we are using to treat different, drugs that are available to treat hepatitis C virus are going to be really, really important. So we'll come back to that in some time. Okay. So now you have started to initiate the treatment, and what are the drugs that we used to give? So right now we have two types of drugs. So as for the treatment is concerned, 2 types of drugs are available. So one is going to be the parenteral regime. Parenteral regime once again is the interferon alpha, especially the pegylated interferon alpha. That's what we are going to use. This is completely outdated nowadays. We don't use. Second group is the oral drugs. Oral drugs, we have direct acting antivirals and ribavirin. Ribavirin is there, and the second group of drugs is called direct acting antivirals. So these are the drugs that we are going to currently use. Current regimes use DAS and ribavirin only. DAS stands for directly acting antiviral drugs. So what are the directly acting antiviral drugs? For that, we need to know the replication cycle. Remember, this is not something to be wasted on time so much, because this is not that important. So remember, hepatitis C virus basically enters the side pathway. As I told you, hepatitis B virus enters this route directly into the hepatocyte. But as far as hepatitis C virus is concerned, they enter the side near the tight junctions. So you have tight junctions here between the 2 hepatocytes. So basically, hepatitis C virus tends to enter the side pathway, side route. That's how they enter. Because these tight junctions are very important, because they use some molecular signaling near the tight junctions to enter into the hepatocyte. So hepatitis C virus enters, and they will uncoat, and they're going to release the RNA. Remember, like hepatitis B virus, hepatitis C virus has nothing to do with the nucleus. They don't enter the nucleus. This RNA, once it is released into the cytoplasm, they will enter the ribosome. So under the influence of ribosome, they will be forming a single polypeptide chain. They'll form a single polypeptide chain under the influence of ribosomes. And this polypeptide chain, you have to enlarge and see. So once you enlarge this polypeptide chain and see, there are a different group of proteins in the single polypeptide chain. One is called structural proteins. You have many structural proteins there, core, envelope proteins, E1, E2, so many things are there. Then we have non-structural proteins, which means these are important for function. Structural proteins are core, E1, E2. These are the 3 classic structural proteins. Non-structural proteins, P7 is there, which is an ion channel. Then we have NS2, non-structural protein 2. Then we have NS3-4A complex. Then we have NS5A. Then we have NS5B. So each and everything has a different purpose. In that, this NS3-4A is something that is going to act as a protease, which is very, very important. So the NS3-4A is the one that is going to act as a protease. And this NS5A protein is the one that is going to act as a viral polymerase, RNA polymerase. You need polymerase because they have to replicate the copies of mRNA. This RNA has to be replicated to produce more viral particles. So that's polymerase. And NS5B, you can think of probably a transcriptional activator. transcriptional activators. That is the function of this NS5B. So you can target these three proteins. So because the current antivirals target these three proteins, they're called as direct antiviral agents. So DAAs. So there are some drugs that inhibit the protease. The drugs that inhibit the protease are called as privirs. Basically, there are many privirs. Whenever something that comes with the privir, it's a protease inhibitor. And what are the privirs we have? We have many privirs. We have semiprivir, not used nowadays. Then we have bosuprivir, not used nowadays. Then we have paritaprivir. This is the only previr that is used very commonly nowadays, and it's pan-genotypic. It is effective against all the genotypes. That's why it's a very common drug used among the protease inhibitors. The rest of it we don't really use. And next we have the polymerase. Polymerase basically are NS5A inhibitors. So typically they will be called as ASVIRs. So we have many ASVIRs are there. So we have ledipasvir, commonly used drug nowadays. Then ombitasvir. Then we have daclatasvir, very effective drugs. Then we have velpatasvir. And many new drugs are coming up. So I'm just telling some examples. And again, velpatasvir is a pan-genotypic drug, which is effective for all genotypes, very commonly used drug. In this, the ledipasvir and velpatasvir are very commonly used in Indian regimes. And apart from that, NS5 inhibitors, these are transcriptional activator inhibitors. These 5 inhibitors will be typically called as buvirs, because you can remember B stands for buvirs. Buvirs we have, so fosbuvir, very commonly used drug. Then we have dasabuvir. Then we have so many other drugs also. So fosbuvir is a very commonly used drug, but apart from that, other drugs are not very commonly used in this particular group. So, but nevertheless, any new drug, if they come, also they will end with buvirs if they are NS5 inhibitors. They will end with asvirs if they are NS5 inhibitors, and they will be ending with privirs if they are protease inhibitors, of course. So these are how you remember. These are the DA group. These are called as direct acting antiviral drugs. And along with that, we do have the ribavirin, which is also used in selected scenarios. Ribavirin is not used in all the patients. In selected scenarios, especially the patient is having cirrhosis, then ribavirin is one option in certain scenarios. Especially for genotype 3 patients with cirrhosis, definitely we can use ribavirin for sure. But again, the combinations of what drugs you are going to use for what type of genotype is beyond the scope of the current discussion. There's a separate algorithm for that. ASLD guidelines will give differently, ESL guidelines will give differently, and APASL guidelines will give something different. So it depends on the local prevalence of a particular genotype. So no need to worry about all this. No, they're not going to ask anyway. The most important thing they'll be asking is what are DAS and what are the groups under the direct antiviral group. And pegylated interferon alpha, whether it's used or nowadays, we don't use it. And currently we are preferring interferon-free regimes. We are only using the oral drugs nowadays. We are not going to use the interferon alpha anymore. And remember the total duration of treatment. Astonishingly, once upon a time, hepatitis C virus is believed to be, untreatable. Right now, just with 12 to 24 weeks of therapy, hepatitis C virus is completely treatable. It's a completely treatable entity. So which means that you can clear off, you can declare the patient as cured. So the modern antiviral drugs has a chance of achieving sustained viral remission. That's called SVR. Rates of SVR exceed 95%, literally 100%. And the rates of SVR is literally 100%, and it can exceed 95% according to theoretical values. So which means they are so effective drugs. SVR means sustained viral remission. That's what we call SVR, and which means you can declare the patient as cured just with 12 to 24 weeks of treatment. So again, 12 weeks or 24 weeks depends, but maximum up to 24 weeks. That's the idea. So within 24 weeks, you can actually cure the patient and declare them free of hepatitis C virus, which is really, really important. And one more time, remember here the virus is basically cytopathic. Virus is cytopathic, which means there will be a cytopathic nature of the virus. So unlike hepatitis B virus, which is not cytopathic, this virus is basically cytopathic only. And currently, we don't have a vaccine for hepatitis C virus. We don't have any immunoglobulin for hepatitis C virus, which means there is no pre-exposure or post-exposure prophylaxis for hepatitis C virus. And what about the breastfeeding? Breastfeeding can be done, and LSCS need not be done just because the patient is hepatitis C virus. These are the current guidelines. Breastfeeding is not a contraindication. Just because the patient's mother is having hepatitis C virus, and just because the mother is having hepatitis C virus, that does not become an indication to do a LSCS. That's all. So this is all about hepatitis C virus. And hepatitis C is basically quite simple, and there are very few questions on hepatitis C virus, and I think this must do it. And you must be knowing this at least for exams to answer questions on hepatitis C virus. I think it's fine so that we can take a short break and come back after some time and discuss on other aspects of liver disease as well. And we have very few like alcoholic liver disease, autoimmune liver disease, and metabolic liver disease. And once we are done, we'll be moving to hepatocellular cancer and finish off the discussion of liver. So do you understand till now, so that we can go for a break and you can come back at maybe 8 o'clock next? Okay. So if you don't have any more doubt, then we can wind up this particular session. Okay, cool. Let us wind up the session. Thank you very much.